Welcome to another episode of Autoimmune Alchemy. I'm Dr. Micah, your host, and today we have Dr. Carol Wada. She's a board-certified allergist, immunologist, lifestyle medicine physician, Sjögren's patient, and the founder of the Immune Confident Institute. I'm so excited to talk to her today about Sjögren's mast cell activation syndrome and a new therapy that she's doing in her office. So welcome to the show, Dr. Carol Wada. I'm so honored to speak with you today.
Oh my goodness. This is like a homecoming and chatting, and so excited to be here and so thankful to reconnect with you, Dr. Yu.
We've known each other for a couple of years on social media already, and we're both very unique as doctors because we're also patients with autoimmune diseases as well. So it's not common to find another doctor with another autoimmune disease, which puts us in a very unique position to treat patients. So I wanted to talk to the audience about your story as a Sjögren's patient, how that journey started, how does it look like, and how has it helped you with patients?
It's a little bit of a long and winding road. I really now see kind of my health experiences from the time of college up through about 6 years ago when I was officially diagnosed with a different set of lenses, because really what I've learned about Sjögren's as a patient and from fellow patients looks a little bit different from what I learned to pass my boards. And so, thinking back to college, I had a couple of episodes of swelling of my glands. So my parotid glands, I had a clogged salivary duct that was quite the hit I went to a clinic that was staffed primarily by medical students and attendings. So I was an interesting patient. Right before I went off to medical school, when I had that clogged salivary gland, everyone had to come in and look at it. And really, though, it was, fast forward through all these ups and downs, that health things that, frankly, I did a really good job of trying to ignore. And my body was increasingly loud about saying, hey, gosh, you need to take notice of what's going on and to slow down. And that really came to a head about 9 months after I had my second child, Josie. I went for a dental checkup and the hygienist said, goodness, Kara, your mouth looks really dry. Are you on any medications that could be doing this? Like, what's going on? And that really was kind of that comment that shifted my view of the fact that I hadn't been able to wear contacts or mascara for years because my eyes were dry. I had back stiffness that got better when I was pregnant, which seemed weird because all my girlfriends, their backs hurt when they were pregnant, but I felt great. And I had this really weird episode of anaphylaxis without a good reason after I had my first daughter a couple years previously, and a few other things along the way, like the glands and stuff. And I was like, okay, I bet I know what this is. And so I went home, I scheduled through my chart, my appointment with my primary care doc to say, hey, really worried. I've been super exhausted. My whole body hurts. My mouth and my eyes are really dry. Can we test for Sjögren's? I had that privilege of knowing what it could be. I knew my primary care doc because we had some teaching responsibilities. We were in the same university system. And she was very kind and listened and examined me. And I think in her own way was really trying to reassure me that, like, oh, I think everything's going to be fine. I bet you're just tired because you were a mom of two. You are in your second year as a full-fledged specialist. You have a lot of patients you're seeing, a lot of stress. I bet you're fine. But I guess we can get the labs. So she ordered the SSA and SSB antibodies, and they were markedly positive. And then, so I text message again, a lot of privilege. I text messaged my girlfriend from fellowship, who's now attending rheumatologist. We had done our core immunology studying together. And I was like, hey, Alexa, I need your help. She's like, oh, Sjögren's, that's no big deal. And I'm paraphrasing, of course, like, if you have to have an autoimmune disease, that's the one you want, kind of type, discussion. But let's get you in. Let's do the other labs. Let's make sure everything's fine. And so we do that. And then the labs start coming back, and it's like ANA really high, rheumatoid factor really high, complement low, total protein, my IgG level was like 2,400, which is really high. And she like messages me. She's like, actually, let's rethink this. Like, and knowing what I know now, like several of those markers were pretty concerning that I had pretty active disease and then it was higher risk disease and that we did need to do something about it. But really, all along the way, both personally, how I treated my own symptoms, but also how my good friends and colleagues too kind of downplayed the seriousness of what Sjögren's is and often is and can be, and just those symptoms being real. And I think, in hindsight, I hear that experience across the board when it comes to folks who find me because there just is this lack of really listening, being able to listen to patients, to hear them, to believe their lived experience, and to validate that, even when and especially if we can't totally explain why they are feeling what they're feeling. And I think that's a huge gap. And it's something we're really missing the mark on as a whole healthcare system. So that's what I really sought to change through my practice and kind of career change in recent, which I'm sure we'll talk more about.
Yeah, yeah. Sjogren's is, a difficult disease, and
Yeah.
it's often misunderstood as in it's mild, but it's not often the case that it's always mild. So I know you talked a little bit about your Sjogren's story. Can you tell me what Sjogren's exactly is for the
Yeah. Yeah. I know but yeah. So Sjogren's is an autoimmune disease. It's now considered Sjogren's disease. Oftentimes, when you Google it, you will still very often see the term Sjogren's syndrome. That's what it had been known by for decades up until just this last year. It is an autoimmune condition that most often is characterized by profound fatigue, body pain, and dryness. Those are kind of the three key symptoms. But what's interesting is for some patients, dryness is something that can occur a little bit later on in the disease process. Sometimes it's earlier, but sometimes it's also later in the disease process. Oftentimes, Sjogren's is taught to us, at least it was taught to me, as a pretty rare condition that primarily affects women of a certain age. And to some degree that there is a little bit of truth in that, the women part. But the reality is that it's not rare. It's just rarely diagnosed. It actually affects about 1 in 100 people, which is on par with celiac disease. It's actually more common than lupus, which, everyone's kind of heard of lupus or knows someone with lupus.
Mhm.
It affects 90% of those it affects are women. So there is a female predominance, but it can affect any gender at any age. And the actual evaluation is a little more challenging, as you alluded to. About 30 to 40% of people, it's estimated, have normal blood work.
Mhm.
And so what will kind of clue me in talking with someone doing an initial evaluation is if I see other diagnoses on their list, fibromyalgia, IBS, chronic sinus infections, migraines, like there tends to be a significant neurologic component with Sjogren's. It's the number one autoimmune cause of conditions like POTS, where your nervous system and your cardiovascular system aren't communicating well with one another. And those aspects to it don't often come up in our standardized test questions, right? What we study for the test is the labs that are positive 60 to 70% of the time. We learn about the impact on the dental health. We learn about the female predominance. Maybe the dry eye symptoms will come up. The swelling of the glands will come up. But other aspects of that disease, especially for your general internal medicine boards, the allergy immunology boards, I can't speak to the rheumatology boards, but those are the parts that are tested. And those are the parts you remember. And everything else that maybe gets mentioned along the way kind of fades away. The patients aren't often coming to the doctor saying, hey, I'm making this appointment because I have really dry eye. Maybe the eye
Mhm.
doctor they are, but they're not talking to the rheumatologist necessarily about that or the allergist about that.
And also, when they do present with symptoms that could be Sjogren's to the primary care doctor, sometimes they're not even referred to the rheumatologist. They're going around in
Yeah.
circles to other specialists. And
Yeah.
it's very
The
frustrating.
ENT, the ophthalmologist, neurologist. Yeah. Dentist.
Right. So for your Sjogren's symptoms, so you had sounds like the body aches, the salivary gland issues. What other symptoms
Yeah.
did you have as a patient?
Yeah, so definitely dry eye, dry mouth. I remember a somewhat awkward conversation with my OB-GYN after I was like newly married and, having, because that dryness can affect you in other places too, that you wouldn't expect in someone in their late 20s or early 30s, as I was at the time. And the other, like, those were the main things that kind of came up. I think what really hit me that, frankly, I don't know if or when I would have actually made an appointment for an evaluation had it just been the fatigue, but the fatigue was really profound. I also kind of shortly after I was diagnosed, I went down, the type A personality, people pleaser, do all the right things rabbit hole. And so I started doing the superfood supplements and working out really hard on my Peloton so that I was getting PRs all the time and just trying to do everything right because, or what I thought was right, because what I knew about Sjögren's was that, gosh, we start people on hydroxychloroquine or Plaquenil, which is pretty mild in regards to kind of the medications in our toolbox. And then there's this huge gap in treatment. And if the proverbial what really hit the fan, then you threw rituximab in.
Hmm.
I will say, as an allergist immunologist, my experience with rituximab is seeing patients after the fact that need IVIG because we've wiped out their antibodies or their B cell function. And so I only saw the bad things that happened after Ritux, right? I didn't see like just the success. And that did not sound good to me. So I was like, I'm going to use lifestyle for all that it's worth, and maybe that will make all this go away. But then I started having daily fevers. I ended up itchy and my urine turned dark and I had yellow eyes. And I was like, oh, 4-letter word. I ended up with a pretty significant liver injury. We attribute some of it to the superfood supplement I was taking because when I stopped that, it improved. But I also do wonder to what degree did that autoimmunity play in. I certainly was working out way too hard for, kind of, I'm sure, overdoing it in that regard. My ability to manage stress was not good at that point. There were a lot of things that, like, in hindsight, knowing what I know now after lifestyle medicine and some functional medicine training, like, I'm sure we could nerd out at another time, but I'm sure my little mitochondria were like, oh, what are you doing? Yeah.
Yeah. Did you get the nervous system symptoms too?
Yeah. And I don't know that I didn't recognize them as such at the time. I've always been someone who has been more prone to being vagal-y. Like on my OB-GYN rotation, the operating room would always be really warm because they wanted it to be warm for the baby when the baby came out. But that standing in the warm room, in the gown, like that heat intolerance plus the standing still, I would get very like I would have to sit down and scrub out because I would feel like I was going to pass out. And I still have those issues. Like I haven't gone through the official diagnostic process because there isn't a ton to do, but I have some orthostatic intolerance that has kind of been long-standing. Have had a long history of headaches, that started in middle school and were just attributed to kind of cyclical things that had some migraine-like qualities to them. And I had an episode, and I can't actually remember if it predated I think it was after my diagnosis, but I had a period of time that I was convinced my thyroid was going haywire because I was super cold, super hot, like all these things. And in hindsight, I'm like, was that just some dysautonomia or this misfiring of my autonomic nervous system that was going on? Because my thyroid stuff like that, all that lab work was pretty stable. So
I
it's interesting kind of looking back through your own self as like a patient and trying to tease that out.
Yeah, well, it gives you better insight for your patients too. So
Yeah.
you had all those symptoms on this journey. So are you still experiencing some of those symptoms, and what have you done to help yourself
Yeah.
improve over time?
Great question. So I would say I am markedly better placed than I was 6-ish years ago by far. I think some things that truly have moved the dial. One is I've realized that for me, sleep is a huge lever. I need good sleep most nights of the week. I need it to be good quality, good quantity, and doing things to help support that have been really critical. Even when it comes to like I'm in my early 40s. And so addressing some of those perimenopausal changes and things like, gosh, my sleep is so much better now that I'm doing that. It's like, oh, wow. Learning how to manage my stress again. I've always been a people pleaser, type A, hard on myself, and really learning tools to have this continually coming back to like self compassion and a mindfulness practice and things. It's like, I still need that constant reminder, but gosh, my ability to just reframe things and take myself out of some self-imposed fight or flight situations like has really been huge. Certainly nutrition and movement kind of follow right behind. I also have been really excited about some of the developments that have happened within the Sjögren's pharma space. So there are multiple drugs in clinical trials. And there was an opportunity where there was a clinical trial enrolling, a phase 3 clinical trial. It's about an hour away from where I live. And frankly, when I initially looked at the medication and how it worked, my initial thought was like, oh gosh, I know what that receptor is, what it does. Like, I bet this is really, I wonder about the side effects. And so had a lot of that,
Hmm.
but the phase 2 trials, the side effects looked pretty minimal, was not as immune suppressive as I would have guessed based on the mechanism. And so I decided to screen for the OASIS trial, which is Dazodalibep. It is a 90-minute infusion that I've been getting once a month for probably about the last 15 months. So I completed the trial, initial trials, 12 months long. And then now I'm in the open label extension, meaning I'm pretty sure I was in a group. There are 3 groups in the trial. One got placebo, and there were 2 groups that got medication, like active medication, but at different dosing.
Hmm.
Pretty sure I know what group I was in, and I'm pretty sure I've been getting med all along. The open label extension, the folks that got placebo then were divided into one of the 2 treatment groups. So I just rolled over into that open label, and I've had some pretty significant improvement in my dry eye and dry mouth kind of since the beginning. I've tolerated the infusions well. And I'm really excited because there are multiple other drugs with different mechanisms or different ways that they work that are
Hmm.
also having some pretty substantial benefits that they're seeing in patients. And so I think we're on the cusp as a community of patients and also as docs who care for, us as patients to really see a huge shift in not only disease awareness, but also the tool in our toolbox to help patients with symptoms and pretty targeted treatments that really the side effect profiles are looking pretty reasonable, especially when you're talking about, things that do suppress the immune system or alter some of those pathways.
It's pretty exciting to have a new drug coming on the market for Sjogren's because it's been a long time.
Nothing.
Yeah, there hasn't been any specific biologic that's been developed over the past like 20 years, or in general, we use hydroxychloroquine,
Yeah.
we might use methotrexate, Cellcept, rituximab, but there's no biologic that has been approved specifically for Sjogren's. So it's really exciting.
Yeah. And even when they've looked at like some of the medications that were substantial changes in rheumatoid arthritis and psoriatic arthritis and lupus, they haven't panned out really when they've looked at their usefulness for Sjogren's. And so to have this whole new category of meds really coming into play, there is some overlap for a couple of the drugs that they're also really look to be quite helpful for myasthenia gravis, which is another little more rare condition, but some neurologic impact. I think one of the big gaps that the patient community is really concerned about is these clinical trials are primarily and overwhelmingly focused on folks who are called seropositive, so people with abnormal blood work. And we mentioned 30 to 40% of the patient population has normal blood work.
Mhm.
And so that group of patients is just really, I think, understandably frustrated that they have not been a part of this research, wondering if these medications are going to help them. And so that's why I'm bringing it up here is like, gosh, if we can get in pharma's ear to say, hey, like, I realize this isn't, as clear cut, but these patients are really suffering. We need to have options for them too. Let's look at it.
So it sounds like you're part of a clinical study. You've been doing well with it. Have there been any supplements that you've taken that have really helped you over time? Because that's the number one question
Ah,
for patients.
yeah. So I will say In general, I have been on the more cautious side with supplement. I still like to do some self-experimentation for sure. But after that run-in with the liver injury and a liver biopsy, like I just hit the like pause button and like, okay, let's just make sure. But I have been pretty consistent over the years with omega-3 fish oil. And there's one that's out there that I do think helps a bit better. It has turmeric or curcumin in it. And it also has some glutathione in it, which I know there is some question of how much that's absorbed, but that combo seems to work better than when I take the same brand, same strength without those two other ingredients. Presumably, one of those two things is doing something. And then that's the primary one I've stuck with over time. I think otherwise, on an ideal week, I'm trying to get, plant predominant diet and not whole food plant based, but really trying to get a wide variety of colors and flavors and fiber, prebiotic, probiotic rich foods in the diet. We're super fortunate where we live. We're actually going to get it tonight. So that's why I was kind of smiling. There is a local Mediterranean restaurant where, gosh, I can get this bowl that it happens to be, a plant-based bowl. And it has, gosh, probably at least 15 different plants and herbs and spices and legumes, whole grain kind of combo in there. It's delicious. And so we try to, and it's not terribly expensive. So we try to like think about those things we have 3 kids. So what are some things that we can get where it's healthy, it's affordable, and also it does, there's a convenience factor too. And so I use a lot of the idea of food as medicine as well.
That's great. Yeah. I'm also on a plant predominant diet as well, and it's helped me a lot. And the most challenging part about eating out is finding a good restaurant that will offer all those
Yeah.
options, because there's
Yeah.
not out there. You have to be living in a decent area like with those options. So I'm glad.
Yeah. Well, if we can ever get you out to Columbus, we'll take you to Brassica because I think you'd really like
Oh
it.
wow, brassica, like the brassica
Yeah.
vegetables.
Yeah.
Very
Yeah.
cool.
My in-laws, we were chatting before we hit record. My in-laws live closer to Dr. Yu. And when they visited, they're like, gosh, we wish this place and a couple other similar would open up spots in California because they're that nice combo of yummy and healthy.
Yeah, we'll definitely, if you come over to Newport Beach where our office is, we can definitely go grab some healthy options. There's a lot in the area. So I'm excited for
Well, I'm going to take you up on it when we're
Yeah,
out this
let's
fall.
do it. So I know that we want to talk about MCAS, but I don't think 10 minutes is enough justice
Oh,
to do for MCAS. So we'll have
yeah.
part 2 for MCAS specifically. So we can just keep focusing on Sjögren's here. So
Yeah.
the frustrating part about Sjögren's to me is that your antibodies can be negative. And usually when that happens, we can, as rheumatologists, we tell patients, maybe you want to do a salivary gland ultrasound or a lip biopsy, but sometimes that is negative as well. And sometimes
Yeah.
patients will have all these different symptoms that sort of scream Sjögren's, but a lot of rheumatologists are very hesitant or are denying the fact that the patient even has Sjögren's. Have you seen that in the patient community at all?
All day, every day. Yeah, I was going to ask if I had it was a bit of a rant in writing that I wrote up for Kevin MD not that long ago. There are these conditions, and it kind of nicknamed them clinical ghosts. I think seronegative Sjögren's is one, chronic fatigue, ME, MCAS, and dysautonomia. These conditions that truly oftentimes really are a clinical diagnosis. And what I think is happening is our generation and even the generation before us of physicians, we have had such amazing access to diagnostics, right? That give us black and white answers. And even though we were taught as first year medical students and for our education, like treat the patient, not the labs, treat the patient, not the, when it push comes to shove, when you're in a situation and in a system that essentially wants you to see more patients in less time, you have to take shortcuts in your process, right? Like you need to get through that day faster. And how do you do that? You rely on the test results rather than developing that trust in your clinical skills and your clinical judgment. I think there also is this, we don't want to be wrong. We don't want to get sued, right? Like there are some of those legal kind of things that, thing. But my question in that article was like, are we doing more harm? And I think we are, by having this bar set so high for what we, use to make that diagnosis, that we're missing people.
Hmm.
As allergists, we, for the longest time, were, and as internists and pediatricians, very concerned about, we want to make sure if someone had an allergy to a medication, especially penicillin, that it was
Hmm.
on their list. Got to make sure it's on there. We got to avoid it. We got to avoid all those similars, right? Because if we give someone a medication they're allergic to, we're going to get sued. We're going to cause harm. This is terrible. What we realized, though, was by having that label on someone's chart, we actually were doing more harm than good. Patients were not getting the gold standard treatments. They were getting antibiotics that had much broader spectrum and had downstream effects of causing bad diarrhea, longer hospital stays, increased cost of care because they were having more complications. What we realized was we were working under this assumption that we were doing good, right? When really we were doing harm. And I think we've gotten ourselves in the same predicament with being so reliant on labs that are really good, but they're not perfect. And we need to remember, and going back to, those elements of specificity and sensitivity. So as docs, we're taught, like, how good is this test? How good is it at picking up a truly positive disease state? How good is it ruling out a truly negative disease state? And there's always some wiggle room for error within that test, even when the test is being done perfectly. And we sometimes forget about that when push comes to shove. And my call to our peers is to say, hey, we need to, like, believe our patients. They're not taking time out of their schedule. They're not paying their copay or the consultation fee to come see us just for kicks. Like, they're suffering. There's a reason they're there. And they're not just the worrying well folks. Like, let's believe them, even if we can't explain it, and let's connect them with someone who maybe does better understand. And let's just realize that our labs have some limitations.
Exactly. And there are all these immune system disorders, whether it be Sjögren's, lupus, mast activation syndrome. It's a gray zone. It's not black and white. And it's very frustrating for a lot of the patients because they're running around 10 doctors not even being diagnosed.
Yeah. And as allergists, this will be my one little comment on mast cell. As allergists, we have kind of been the kings and queens of mast cell physiology, thinking we know all of it. But our focus has really been on one receptor in mast cells, something called IgE receptor, because that's how allergy works. There are dozens, if not hundreds, of other ways these cells can be turned on. There are dozens, if not more, of these different chemicals inside these cells, but we rely on one blood marker and say that's the end all be all.
Mhm.
I think we've kind of, like, we've gotten distracted, right, from the entire picture and realizing that these cells, like, we weren't born and our ancestors weren't born to be allergic to peanuts, right? These cells had a much different and greater purpose. And I think we need to zoom back out and be a little bit more, in some degrees, humble about what we know and what we don't know. There's a term a colleague shared with me recently called earned dogmatism, where sometimes when you are an absolute expert in a particular area, it becomes harder to change your mind about things that you think you're expert in, but the science maybe has evolved and changed. And I
Mhm.
think we need to be thinking about that more.
Yeah, sometimes it's very frustrating for the patients. And I'm very happy that you're in this community because you're such a great patient advocate. Being a doctor and a patient is so important, especially in the Sjögren space and being an allergist as well. But before we end this podcast, because we're going to bring you back on, Dr. Wada, for part two, just on mast activation syndrome. But I know you have this ISLIT protocol you're doing in your office, and I want you to talk about that. How can it help patients at your clinic?
Yeah. So at the Immune Competent Institute, we really are working to bridge this spectrum between allergy and autoimmunity because they often are found in the same humans. And if we have an easy win to down inflammation, let's take that. Let's turn down inflammation because really it can help the body kind of come to this place of being able to, in many respects, kind of heal on its own and kind of refine that balance if you set things on the right course. So immunotherapy or allergy shots traditionally mean you go to the office, once a week to once a month for 3 to 5 years. It's not very efficient in many ways, both the logistics of it as a patient, but also the science behind it. And so for about 25, 30 years, there are some amazing immunologists in Switzerland who have been studying delivering that allergen directly to the lymph node, which is where that immune system change occurs. And it turns out if you do that, if you use an ultrasound, you put that needle right in the lymph node, which is much easier than you may imagine. You can use much less allergen, and you can do that process 3 visits over 8 weeks.
Mhm.
Maybe a booster, maybe, but probably not even that. And that's all you need. And so in my mind, gosh, when folks are having swollen arms, getting achy after their allergy shots, if we can use less allergen, put it directly where it needs to be in less time, and then support that with lifestyle, too, helping improve sleep and nutrition and movement. It's the perfect recipe for accelerating that immune system reset. So we've called it ISLIT, Accelerated Immune Reset Interlymphatic Immunotherapy program. And so that's what we're offering through the Immune Confident Institute. So we see folks from all over, but they do have to be willing to come to Columbus to see us for the procedure.
Got it. And is there any side effects of this procedure?
Generally, it's super well tolerated. Sometimes day of or day after, folks will have a little swelling, a little discomfort in the lymph node. We usually use the lymph node in the groin area. So we're away from major nerves, major blood vessels, lower risk of reaction than with like a typical allergy shot. Yeah, folks typically do great and we'll see benefits within 12 to 16 weeks after they start the process.
That's great. Awesome.
Yeah.
So how can people find you on social media? How can they find their clinic?
Yeah.
Because I know you
Yeah.
do great work in the community.
Thank you. Yeah. So I have weekly YouTube over at Dr. Kara Wada. And then my website is drkarawada.com. On Instagram, I'm the Immune Confident MD. And those are the main places where I'm hanging out.
Awesome. I'm a big fan because it's so hard finding doctors that are patients because you understand it from both the doctor and the patient side. And we really need that in the community. So thank you so much for everything you do.
And thank you for what you're doing and continue. Like, I am learning so much and I'm so excited to see you relaunching this platform. And I have it set to subscribe so I can get my weekly
Oh,
dose.
thank you so much. Well, we're going to bring it back for part 2, just to talk about mast cell activation syndrome, because that can take another half an hour to an hour conversation.
Yeah, we could have a whole day on that.
Yes. All right. Well, thank you so much for being on today.
Take care.